Okay, good evening, everybody. I'm extremely honored to share the next hour with such an international audience. We will talk about new innovative dental material that I work with, and I will share my clinical experience with you. Let me first of all talk about me. I'm a graduate from University of Montreal, Quebec, Canada in 1988. Montreal is located in the French-speaking area of Canada, so I'm a French Canadian, and of course I have a French Canadian accent. English is my second language, and it's always more challenging for me to speak in English in front of colleagues. I am a general practitioner. I've got over the years some fellowship, and I've been a laser user from since 2005 and a certified laser trainer. I did also a mastership in laser dentistry in Aachen, Germany in 2014. I am a consultant for many different companies, SDI, 3M, Colteen, Biolase, and Planmeca. Today, I will talk about innovative dental product produced by SDI. I'm also an invited speaker at University of Montreal, teaching to final year students laser and CAD/CAM dentistry using the Planmeca system and the 3M system. I am also the dentist of the French-Canadian version of a TV show 10 years younger. But more important than everything else, I am a full-time practitioner like every one of us. This is me with the TV show. You can see over here in the center the fashion designer, the cosmetic dermatologist, the hairdresser, the makeup artist, and the dentist over here is me. And I can tell you that, like in all those makeover show, the dental segment is very important, and it's very important for all the participants. So let's go to the lecture. And what I will do today. The goal of this presentation is to present new composite and new shade guide developed for simple procedure in day-to-day practice. This is what I do every day in my home practice. And I will explain why we should think differently regarding color choice in restorative dentistry. We've been doing things again and again the same way, and I think there's a better way now. I will explain why some composite could be a plus in your practice, especially if you're a cosmetic dentist. In the second part of the presentation, I will talk about a new adhesive with interesting clinical feature. And finally, I will give you an approach to tooth whitening in extreme condition. Okay, I will just take your question at the end of the presentation. I have a lot of material and many interesting topic to share with you tonight. So I will answer the question at the end of the presentation. Okay, let's start with the natural tooth. The natural tooth is the final objective in restorative dentistry is to copy that super complex structure. And the natural tooth, of course, is made mainly of two constituents. Okay, we're talking about enamel and we're talking about dentin. And as we already know, most of the color is coming from dentin. Okay, dentin is opaque, is quite opaque, and is highly saturated, and is also fluorescent. What is the importance of the fluorescence of dentin? I mean, when you make a restorative material, you want to copy nature. You want to copy natural tooth. So this is a feature that we like to have in any restorative material. On the other hand, we have enamel. Enamel is completely different. It is translucent. It is low saturated and opalescent. And another important feature about enamel is the fact that the thickness of enamel is not the same in the middle of your tooth, in the gingival third, or in the incisal edge. All this will influence the final color of your tooth, and this is a very complex structure. Okay, let's take a natural tooth and see what happens when the light touch the tooth. Okay, if it go at the incisal edge, we already talked about the fact that enamel is very translucent, so the light is not blocked, and we will see some translucency. On the other hand, if the light touch dentin, it will be reflect and it will bounce back, creating some optical effect. And of course, we also see it on the surface of enamel. More than that, just to make it a little bit more difficult, we also have some kind of scattering within dentin and scattering within enamel. So all this will create the final color of your tooth, and this is a very complex structure to copy. So doing a restorative material is not easy to copy such a complex structure. Okay, and what do we have to take the color of a tooth? We still work with a technology from the 50s. It's kind of weird because actually in our office we work with many amazing technology like digital radiology, digital impression system, CAD/CAM, whatever we have, we all practice in very high-tech dental offices, but we still use that Vitapan shade guide that was made at the origin for denture teeth, for porcelain denture teeth. And I think that we should get rid of that Vitapan classical shade guide, and we have better solution now that will help us get better result with our patient. Okay, mainly shade selection always been a problem. Okay, we in my office work with dental assistant, and basically we do it together. This is a teamwork, and I share it with my assistant, and she's probably better than me for color choice. The fact is, we were looking at the old tooth or only the incisal edge. That was the first mistake that we did, and this is the way we learned with the Vita shade guide. And for this reason, we are mainly buying and using body shade in current composite system based on that Vita shade guide again. So is there a better way to work with new composite? I'm sure that there is a better way. And let's be honest, shade perception is very personal. If we try to make a color choice on a central incisor, all the doctors here on the webinar, and we do the color choice, we will probably get 4 or 5 different results. So the idea, it is not an easy task to do, so we must find a way to make it more simple and make it more accurate. When it's time to color choice, I mean, if you go to the car dealer and you say, I want a white, silver, black, or red car, it's very simple. But working with a tooth is completely different. Okay, the color of your tooth is already defined, and in fact, we just have to find out which color it is. I always tell we should let the tooth pick the color, not the shade guide. Okay, get rid of that old Vitapan shade guide and get rid of those A1 and A2 and A3 shade. We have now a better way to be a better dentist and get a superior aesthetic result with our restoration. Okay, let's talk about dental aesthetic and shade selection. Okay, let's go back to dental school and talk about the different factor that will influence the shade selection. Okay, let's talk about, first of all, hue. What is hue? Hue is the basic color of a tooth. Okay, red, blue, yellow. Basically, we have a color. And then we have another important feature, chroma. What is the chroma? This is the intensity of the color. This is how many pigment you have in that specific color. Is it a light blue or a dark blue? All the difference is related to the chroma and how many pigments you have to create that specific color. In dentistry, we also have to deal with value. The lightness or the darkness of the color is a very important features, and enamel is important on that point. So we will talk about it later on, and we will be able to give you a way to achieve an excellent result. Then let's talk about opacity and translucency, the optical properties of the two and the optical properties of a restorative material. Very important. Finally, this is the artistic side of our work, the form and the surface structure of the restoration that we do will give a special optical effect that will be part of the final result that we're going to get. Okay, so let's go back to real life dentistry and see that patient over there. See PEG 2 challenges, and what do we have as challenge in a case like that? Okay, basically this is a young patient. If you look at the central incisors, she had a lot of translucency on incisal edge. We, as dentists, we love those teeth. In my mind, it looks great, but it's quite unusual because very often patients, they don't like it. They say, is it normal? I say, yes, that's beautiful. Don't touch it. We will leave it like that. This is a young patient, and she has a high opalescence of enamel. We see it over there. And in a case like that, we must be minimally invasive. This is really a must. We need a material that will help us to block the color of the mouth. So we need opacity to mimic dentin. And in a patient like that, she's young, maybe she's starting to drink coffee, tea, or red wine. She may also start to smoke. I think it's not a good idea to start smoking, but the fact is we will see some color change over time, and being minimally invasive is an excellent idea. So we will be able to readjust the color of the teeth within the next years if we see some major change. Okay, what are the options? Okay. The easy option to do, okay, we can do porcelain veneers. And in fact, this is quite expensive, and more important, it is quite invasive. Even if we do some minimal prep, it's not the best treatment for a patient like that. And why are we offering porcelain veneers? Because we deal with monochromatic hybrid composite. And we're not happy with the optical properties of those materials. Okay, the dull finish that we get over time says, let's go with porcelain veneers, and we are not at this point conservative. And no treatment at all is not a solution for her. For one more reason, she has some problem of self-esteem. Basically, she's been through 2 years of treatment of ortho, and she wants to have a better option to increase the beauty of her smile. So do we have other option? And yes, we have other option, and it is time to talk about a material that I work with for more than 2 years now. Aura is a composite made by SDI. SDI is Southern Dental Industries. This is an Australian-based company, and they are extremely focused on research and development, and they give us a material that can really help us to achieve amazing cosmetic result with a simple system. Okay, let's talk about this composite a little more. What is different with Aura composite compared to other composite? Basically, this is made like a tooth. Okay, we create a restoration with the same principle as a natural tooth. We have a dentin shade that will replace dentin, and we have enamel replacement. All this to go from a situation like that to a situation like this. Okay, the idea is to get a material that will act like enamel and act like dentin on the aesthetic standpoint and on the optical standpoint. So what I did over there is really easy to do because this material is made to help us in cosmetic treatment. Okay, how does it work? Basically, it works like it's based on natural makeup of colors of enamel and dentin. We have dentin over there, we have enamel on top of it. And the idea is to get rid of that Vitapan shade guide. Okay, we have a shade matching system that we will do very, very fast, and that will help you to give excellent aesthetic results. So how does it work? It all starts with the color of dentin. Okay, let's go back to dental school again and talk about hue. Okay, what is it? What we realize over years, most dentin fall in the red-brown hue. Basically, the A range, it is the A range of the Vita system. This is the range Oracle Dentin Chroma, and this is the core material where we will build the restoration. And how do we make that shade selection? Basically, forget the Vitapan shade guide. Okay, right at the beginning of the appointment, you have the DC shade. Okay, starting with DB, going to DC7. So the idea is to find the proper color of dentin. So where do we put the shade tab? By the way, this shade tab is made of Aura composite. It's not made of porcelain. So the color is what you see is what you're going to get. And I place that shade tab in front of the gingival turn, and I say it may be a DC3. We will check it a little more. I have a specific method to check it again. Then we do the same thing with the second material, the enamel replacement material. So we put the enamel tab right in front of the incisal edge, and this is quite a E2. And for our highly demanding cosmetic patient, what I always do, I double check with a composite that I cure on the tooth. And if I look on the right side of the screen, the color is quite good with the enamel. I'm happy of that. But if I look at the DC, the Dentin Chroma shade, maybe it's a little bit too light. So instead of taking a DC3, I would rather take a DC4 if I had to do a restoration on that patient. Okay, and now we will work like our master dental technician. Okay, basically this is monochromatic. On the left picture over here, this is a monochromatic zirconia-based crown. And what they did after the firing, we have the core material of our restoration. What is the goal of that core material? It is a strong material that is able to support occlusal load, and this is a material that is quite at a certain level is opaque. So the idea of doing a crown with only one type of porcelain will not give you a good aesthetic result, and this is exactly the same situation with the Aura composite. Okay, take your porcelain on this side as the core of your tooth, then you will finish it by adding a very thin layer of enamel on top of it. What are the characteristics of that enamel porcelain? This is extremely translucent, this is opalescent, and we will see through the enamel porcelain to see the dentin core, and all this to create a super aesthetic restoration. We work with Aura composite exactly that way. We have the Dentin Chroma shade and we have the enamel shade, and this is how we will be able to get that optical effect that will give you a super aesthetic restoration. Okay, how does it work with the Aura Dentin Chroma? What it is interesting with that material, no matter which chroma you will use, you will always get the same opacity. Okay, we have a material that is quite opaque, so it's easy to use it as a core material. Then we also have the same hue, is the red-brown hue, the A range of VitaPen shade guide. And we have a large chroma scale, so many different options, all this to help you create a restoration that will really look like a natural tooth. And again, I was talking at the beginning of the presentation about the fluorescence of dentin. If we want to reproduce that fluorescence, we need to have a restorative material with those optical properties, and this is what we have with the Dentin Chroma shade of Aura Composite. What is very interesting about Aura Composite? We have the chroma scale over there, and if we look at this, we start with dB. dB mean Dentin bleach, going to D7. Okay, highly saturated chroma for your dentin. What we have over there is the multi-purpose chroma. I will talk about it later on, but basically this is the same material with more translucency and less opacity. And if we compare the Aura Dentin Chroma to the Vita shade guide, what you will see when we jump from DC3 to DC4 and DC4 to DC5, it is equally spaced. When we look at the Vita equivalent, basically we go to A2 to A3, then we step to A3 to A3.4, and we don't have the same scale. So it's very difficult with the Vita shade guide to get a consistent result with the composite. So forget the Vita shade guide. We have something better now that will help us achieve a more aesthetic result. Then we talk about the value scale of the Aura Composite. Again, okay, we can see that we start with a low value with the DC7. Okay, basically it is much darker, and we will use it for our geriatric patient. But we have a super large scale going to dark restoration to super light restoration. So if you have that patient and she had bleaching 3 times and her teeth are so white that you're not able to find a composite to properly fix their tooth, I can tell you that you will be able with that system to get something to cover the entire scale of color that we need in restorative dentistry. Then the opacity again. Keep in mind that we use the Dentin Chroma as the core material of the restoration, and no matter which color we have the same opacity. Why do we have that opacity? Aura Composite is based on real tooth anatomy and real tooth color and optical properties. This is the main difference compared to the famous Vita shade guide. And again, if you compare the Dentin Chroma of Aura with Vita shade guide, we can see that the opacity of A1 and A2 is less than the opacity of A3, and the opacity of A4 is less than A3.5. So how can we be consistent with a material with a different opacity like that? When you get used to work with the system, this Aura system is very easy to work with, and you will be able to get the proper color. But we talk a lot about the optical properties of the material, and I think if you ask me to find one major difference with this composite compared to the other composite that I work with, we get better optical properties. Improve all the system is based on this. And the Dentin Chroma is a nanohybrid composite. made of very small particles, 0.02 microns, to small particles, 0.4 microns, and highly filled, 81%. And what we have a mix of three resin. We all know bis GMA, bis EMA, and UDMA. And with their special formula is again focused to improve the optical properties to get a tooth that look like a tooth, not like a restoration. On the other hand, the other material, enamel, is completely different. Okay, it is a microfill composite. Okay, with very small particle, 0.02 microns to 0.04 microns, and this is a pre-polymerized microfill material. Of course, like every microfill still on the market, it is the best possible polish that you can get are with those material. And the fact is, actually, with those pre-polymerized version of microfill composite, those material are stronger than the usual standard microfill, but it's still easy to polish to a eyeglass. What is very important, again, those enamel shade will contain some opalescence to match natural enamel. So the idea, find restorative material with the same characteristic as the enamel or the same characteristic as a dentin to give life to your restoration. And I told you that the microfill composite is made of super small particles. So over time, when we will lose some particles on the composite, we won't get that plucking effect of larger particles. So this is a problem with the older version of hybrid composite. I mean, you lose large particle on the surface of your composite, and what you get is a very dull surface and a rough finish over time. And of course, this is not what we want to have. Another important feature of having super small particles on top of your restoration is the smaller the particle size is, the more scattering you will get. And the more scattering you will get, the more blending characteristic that you will get. So the idea, this material, this enamel replacement material, blend very easily with natural enamel. Okay, what we get, even if your color is not perfect, this material just disappear and you don't really see the margin between your restoration and the tooth structure. Okay, I will briefly talk about the MC shade composite. What is the MC shade? Basically, DC shade and MC shade are exactly the same nano hybrid composite. The only difference with the MC shade, it is a less opaque material than the DC shade. And for dentists who don't like to have a lot of composite in their office, I think that MC shade is like the body shade of other composite. And in my practice, it is the ideal posterior composite. I use it for with all my posterior restoration with excellent aesthetic result and good physical properties. So again, this is a nano hybrid composite, and it is I should focus on that point. It is a highly polishable for a hybrid. Okay, Aura has two composite, a nano hybrid for the DC and the MC, and they also have an enamel that is a microfill. But even if they have a super easy polishing material with the microfill, the hybrid on that point is also good. Okay, let's be honest. If you you will see some cases later on, and we can get an excellent polish with this nano hybrid composite. Okay, and how do we make the color choice for those MC shade multi-purpose chroma? Very easy. This is exactly what we've done over years with the Vitapan shade guide right in the middle of the tooth. And this composite blend the optical properties. You will get a very decent color match for your posterior restoration. There's no doubt about it. Okay, I did talk a lot about the superior properties on the optical standpoint and on the aesthetic standpoint. But how is this material compared to the other competitors on the market? And over here we have the flexural modulus. The idea, the lower your flexural modulus is, the stronger is your restoration. So Aura, compared to all those leading composite, is excellent on that point. So you don't have to worry. This is a strong composite. On the other hand, we can see that no matter which composite you take, every composite on the market are shrinking. Okay, this is based on the chemistry of composite, and no matter which one you have, even if your sales reps tell you that you have a low shrinkage composite, all composite over there are shrinking. So we can see that Aura Dentin is shrinking a little bit less than Aura Enamel. Why? Very simple. I mean, you have more resin. This is two different material, and Aura Enamel is shrinking a little bit more, so you should be aware of that. But compared to the other composite on the market, again, it is like the other one in the same range of volumetric shrinkage. Another important features. Okay, talk about polymerization shrinkage stress. Okay, again, they compare Aura Dentin to all the other composite out there in the market, and they all give you some shrinkage stress no matter which company you take. And I will talk later on about a resin adhesive that can counterpart that shrinkage. So this is in the same ball game as all the other composite. Compressive strength now. Okay, we can see that the Aura composite compared to the other one is a strong material. So don't be afraid if you put that on a molar. This composite is able to support occlusal load. Don't worry about that. And radio opacity. Again, radio opacity is a feature on every restoration that we do. We want to have some radio opacity. And again, all the composite out there perform well on that point. We did the radio opacity test with the DC shade, then the MC shade. Okay, we should keep in mind that the Aura enamel shade is another material. And if you need some radio opacity, this material is just there to for an extra effect on the aesthetic standpoint, and it is not radio opaque enough. So keep in mind, for posterior composite, you can use the DC shade and the MC shade, but try to avoid the enamel shade if you really want to have some radio opacity. Okay, at the end, patient judge us for the look of the restoration we do. Okay, if you want to impress your patient, the best way is to do that little extra cosmetic work that will give a wow effect to your patient. It's super important, and to do it, we need to have dental material to help us. And this is what I found with the Aura composite. Okay, I will show you some clinical case. Okay, we will go back to that pec tooth patient. Basically, we see the pec tooth right at the beginning of the appointment. What I did a mix of, by the way, she didn't want to have a highly translucent incisor lead. She said, I have it on my centrals, but I don't really like it. So we did without any preparation, only bonding. So it is a super conservative restoration. I did the core material with a DC3 in the back, and I finish it over it with E2, the enamel shade, and it blends with the natural tooth. And guess what? After that appointment, she said, Dr. Robert, I don't like my white spot, my hypocalcification spot, and I have a small space between my teeth. Can you fix it? So basically, what we did, we gave her a second appointment, and this is what we did. Well, again, my main point is always stay extremely conservative. So do not cut a tooth for your restorative standpoint. Okay, the best tooth that we have is the natural tooth, so keep the tooth structure. I just did a very small preparation to remove those hypocalcification stains. Then right after this, what I did, the same formula again with DC composite in the back to close that dark spot, and enamel on top. All this to get an excellent aesthetic result. And I told you that the optical properties of that enamel, it's just blend with the natural tooth, and it's hard to tell where the restoration finish and where the natural tooth starts. So very good aesthetic result with very conservative treatment. So I think as dentists, we must protect the tooth structure, and to give aesthetic treatment in a conservative way like that should be the way we practice in the future. How do I, someone asked me, how do we cut those materials? So the idea is I do work with Softlex XT from 3M, with the cores going to the fine disc. It is good for the straight surfaces. But I also have in my clinic another material. Of course, there is a lot of polishing system out there on the market. This one is available on the Canadian market, and it is called the ASAP, or the All Surface Access Polisher. Basically, it's made of two different wheels, the purple wheel and the orange wheel, and with a bit of water on you too, it is super fast to get an enamel finish. So within less than a minute, you are able to get that eye gloss that I just showed you in the previous case. And an interesting feature also, it's not a one use polishing wheel. You can sterilize them and use it 3, 4, 5 times. So it is, in my practice, a material that I like a lot. Okay, let's go to another case and talk about that defective restoration on the tooth number 21 and tooth number 9, I think, for our American colleague. This is probably a hybrid composite, and we can see that this material doesn't have enough opacity. Okay, we see that black spot coming from the mouth, and is there a way to get a better aesthetic result without doing a porcelain veneer over it? And the answer is yes. Okay, let's take your Aura shade guide again. Basically, what I did remove all the restoration and the previous restoration, and I just kept a little wall of hybrid composite in the back, and I did treat it with my laser. But the idea is to get the Denton chroma shade that will match the actual color of the tooth. And after this, what I did etch the enamel and etch and prep with my laser. If you don't have a laser in your practice, you can just take a diamond burr. It can do the job. Probably etch the surface. And after that, I did my first layer. The backup layer is the Denton chroma shade. All this with some kind of anatomy on it. So we should keep in mind that the enamel material is extremely translucent, and if you do some anatomy or surface anatomy over here, you will see it through your enamel layer. So let's go to the final stage, and this is what we get in a very short appointment. Okay, it blend much more easily with the natural tooth. And what is very important on that point, I didn't spend 2 hours to do that restoration. Okay, I see on Facebook different Facebook posts, beautiful restoration done by many colleagues all around the world, but spending 2 hours on a composite on a front tooth is not real life dentistry. Okay, we must be able to achieve an aesthetic like this in 20 minutes. Okay, that's the time that it takes to do this patient. So we are efficient. This is real world. I do not charge $500 for a restoration like that. I practice in a middle class area of suburbs of Montreal, Canada, and this is important for my patient to get affordable treatment, free treatment that they can afford, not always extremely pricey dental treatment. Okay, now let's go to the next step of the presentation. We will talk about posterior composite. Okay, the challenge that we have, avoid post-op sensitivity. It's better than it was 20 years ago, but is there a way to be a bit better? Yes, there's a way, and I will show you that way. Decent aesthetic. I talk about decent because, let's be honest, we don't have to spend 2 hours for aesthetic of composite restoration on a molar. Patients don't see the difference. Of course, we want to have excellent physical properties, a long-lasting restoration, and we talk more and more about biocompatibility and bioactive material. So we all know that a common cause of a posterior composite failure is often related to imperfection of the tooth restoration interface. That leads to post-operative sensitivity, marginal discoloration, and secondary caries. So we all know that composites shrink, and due to that stress, the shrinkage upon polymerization is considered the primary factor leading to the loss of bonding integrity. So if you lost your bonding integrity, your restoration for sure will fail quite soon. And according to all the composite that we have now, we have even the low shrinkage composite, they still all shrink. Okay, no matter which company you are working with, we still have that problem of shrinkage. And even if your sales reps tell you that, oh, I have an excellent composite out there, the shrinkage is 1.5%. But you still have some shrinkage, and that shrinkage is a problem that we must deal with, and especially for posterior restoration. Okay, again, let's go back to dental school and talk about that C factor, that configuration factor. Why do we get more post-op sensitivity on posterior teeth than on anterior restoration? The configuration factor is much higher. What is the configuration factor? It is in fact the relation between bounded surfaces to unbounded surfaces. Okay, if you look at that very simple class 1 restoration, you have mesial, you have lingual, mesial, pulpal floor, buccal, and so you have 5 bounded surface and 1 unbounded surface. And it is probably the most frustrating situation as a restorative dentist is to receive a phone call from a patient 1 week before an appointment, and they tell you, Dr. Robert, the filling that you did on that molar, I cannot bite on it. I mean, it hurts. And according to that, especially if it's a very small restoration like that, we want to get rid of that situation and we want to avoid it. And is there a way to do it? Yes. Okay. Actually, what we have, all the current system of adhesive are made with resin. And how do you make resin adhesive? The idea is to get more resin and less filler. And those resin-based adhesive, they all shrink. Okay, so we have a larger, even a larger shrinkage. And what is the meaning of that shrinkage? When we talk about polymerization stress at bonding interface, I mean 5 megapascal. What is 5 megapascal? It is the weight of half a bucket of water. It is a lot of pressure on the interface. Okay, so is there a way to avoid that problem? Can we find something else that will help us to avoid that situation? Okay, what we want to avoid, the shrinkage of the composite, and on the other hand, the resin adhesive is shrinking on the other way, and it creates a marginal gap. And it can also create a white line, and even worse, it can create a crack or even a cusp fracture. So no matter which composite you use, you will get some kind of shrinkage. And is there a way to avoid that problem? And I will talk about that famous, I always like the sentence of that famous scientist Albert Einstein. He was talking about insanity, and he says, doing the same thing again and again and expecting different results. And when we work with resin adhesive, this is exactly what we expect. Expecting different result, doing the same thing again and again. Oh, so is there an adhesive that can avoid stress at the margin, give you a longer lasting restoration, free from sensitivity? This is my main point. Nobody, no dentist around the world like to receive a phone call from a frustrated patient 1 week before an appointment. We want to get rid of that. And the way to do it is not to do another resin-based dental adhesive, but to do another material. And this other material, this is the second innovative product that I will work tonight. We'll talk about tonight. It is the Rivabond LC. What is the main difference with the Rivabond compared to all the other bonding out there on the market? It is a resin modified glass ionomer adhesive instead of being a resin based adhesive. And if we look at different feature of those two type of adhesive, when we look at enamel bonding, we all know that resin based are excellent on enamel, no doubt about that, but resin modified glass ionomer also are good on enamel. But talking about dentin adhesion is much more, it is much more tricky. Okay, it is for sure less predictable. Which type of dentin do you have? And we rely on a micromechanical bond, and all this is not easy to achieve. But on the other hand, with resin modified glass ionomer, we do have an excellent chemical bond. So it is much more predictable bonding on dentin. And we have less micro leakage and more fluoride release. So even if you use a resin-based adhesive, many speakers on adhesive dentistry will tell you to put a glass ionomer under your resin-based adhesive to really get less micro leakage. So, and the main point for me is the no shrinkage that we get with the resin modified glass ionomer. In fact, what we get is a little bit different. Okay, we compare here Rivabond LC with many leading resin adhesive on the market. I don't tell that those adhesives are not good, but that's another product. And the idea, after 30 minutes, we don't have any stress at the interface of our restoration. And in fact, we get a slight positive expansion of that Rivabond that will seal the cavity, preventing both stress and micro leakage. So the idea is to, with that Rivabond, you have an adhesive that compensates for that polymerization shrinkage of composite. So we are getting less and less post-op sensitivity. It's almost never that you will get post-op sensitivity with that adhesive. And we expect increasing life expectation of the composite restoration. So in my mind, this product is a breakthrough, okay? This is a way to counterpart one of the major problems related with contraction of resin composite. So no stress, no stress mean no sensitivity, mean longer longevity of restoration. But this adhesive, is it a strong adhesive? And again, comparing Rivabond to all those leading resin-based adhesive, Rivabond is in the upper area. So the shear bond strength on Denton is excellent. And in fact, it's even higher. Why? Because traditional adhesive need that high bond strength to compensate for shrinkage. And even if you have an extremely high bond strength, if it pull on your margin, you may get a cohesive fracture, and you will get that thin white line around your restoration. So the idea of having this material, it is, in my mind, a breakthrough and a real change compared to all the other resin adhesive that we have on the market. Again, this is a glass ionomer, and we all know that glass ionomer release more fluoride than resin. So the idea, we put an adhesive on the tooth that will protect your tooth. So sounds good to me. This is what we want as restorative dentists. We want to do an excellent restoration that will last a long time if it's possible. Another feature of the Rivabond LC is the flexibility that will in some way absorb the load of occlusion, so that challenge the traditional adhesive with other resin-based adhesive. And the thickness of this adhesive is small, 22 microns, a bit more than the other one, but it's not a big deal, and I will show you how to get rid with that problem. Okay, so in my practice, I use this resin modified glass ionomer adhesive in many situations, like for all my direct posterior composite. I also believe in sandwich technique, so the idea of bonding composite resin to self-cure or light-cure glass ionomer, very good material for this. Sealing hypersensitive cervical area, why not? It's this material has an excellent adhesion on every tooth structure. Adhesive lining under amalgam filling. If you still do amalgam, you can do bond amalgam with that adhesive. The idea is a glass ionomer bond to metal, and glass ionomer bond to tooth structure. So you completely close the gap between your amalgam restoration and your tooth. And in my area, we call it PRR, or preventive resin restoration. What is a preventive resin restoration? This is more than Pitts and Fisher sealant and less than the traditional class 1 restoration. So the idea over there is to be minimally invasive and just remove the decay that you see with a super small burr or with your laser. Then you put that resin modified glass ionomer and your filling over it. All this to help remineralization of tooth. Okay, the idea is not only closing the gap, but to protect the remaining tooth structure. So it is, in my mind, the best adhesive that I can take for that type of treatment. Okay, high radio opacity due to the ion glass filler, we have with this material some radio opacity. And it is important because, in fact, Rivabond is a little bit thicker than the resin-based adhesive. So don't worry, you won't see that white line under your filling. You will be able to get a restoration without a doubt of recurrent decay. And how does it work? Basically, we start with phosphoric acid for 5 seconds. The idea is just to clean the smear layer, okay? We want to make sure that your resin-modified glass ionomer will chemically bond to the tooth structure. Then we clean it with water and we dry it, but do not desiccate it. Why? Because glass ionomer needs a bit of water in their polymerization process. So basically, don't get rid of your amalgamator. Basically, what you will do, you will put that capsule in the amalgamator for 10 seconds. Then with a micro brush, you will poke a small hole in the metal foil. And what you will do, you will then apply a very, very thin layer of that adhesive on every surface of the tooth. And you don't have to dry it. Okay, what I do to make sure that I don't get any pulling in the box of a class 2, I take a second micro brush just to remove the excess to make sure that I get a very, very small layer of adhesive. Then I cure it for 10 seconds and I'm ready to put my composite after it. So stress-free bonding means stress-free dentist. Okay, the main point with this adhesive, no more phone call, no more post-op phone calls. Okay, long-lasting restoration, compensated absorb composite shrinkage, no sensitivity, high bond strength, BPA-free. We are looking for material that are biocompatible and fluoride release. So what else can we ask for? Okay, posterior composite. Okay, this is a real case, a real clinical situation. Basically, what we get over there, I did the prep, and I'm a strong believer in rubber dam. Very often, this is the fastest way to get the best isolation possible. So what I did, etch for 5 seconds, dry the tooth, but not desiccate the tooth. We can see it's a little bit wet on the dentin surface. Then what I do, I will put the Rivabond in a thin layer, remove the excess with a second micro brush, then cure it. And after that, you can put the composite of your choice. Okay, basically, I'm not a strong user of ball-filled composites. So I like to use composite in 2 millimeters layers. This is the Aura composite. First layer, and the second layer is there. And again, no pits and stain in the groove. This is not, in my mind, important. What is very important is to have a good contact point, no post-op sensitivity, and a restoration that will last over time. So all this is done in real clinical situation. It doesn't take 2 hours to do a composite like that. It's a 20 to 30 minutes procedure. And this is after removal of rubber dam. And we can see over there the excellent radio opacity of the Aura composite. So you don't have to worry about that. You will be able to see it very easily on your radiograph later on. And I will finish it with one interesting case. That case comes from the TV show. And that patient came to my office and she has a heavy tetracycline staining with multiple composite restoration, self-esteem problems. She said, do something for me. She has a limited budget. And within the TV show, we have a limited time frame also. So what are the solutions? 20 unit of crown and bridge, too expensive for that patient. For sure, it's not possible. Extraction of upper teeth and all for or denture. There's a dangerous trend here in my area of Canada, and young dentists are extracting teeth and they put implant support denture. In my mind, nothing is better than natural teeth, and I am in the business of keeping teeth in the mouth of my patient. Composite veneers, if we don't treat the tetracycline stains, it will shine through. And what we did for that patient is another way of using our bleaching agent. Okay, I have been working with SDI Pola bleaching product for years. And what I did in that specific case, I was used to tell my patient it won't work because you have tetracycline stains. So basically, remember the color of the teeth at the beginning. And what we did, we start with Pola office to start the bleaching treatment. Then what we did, this is the first treatment, and of course, I'm not satisfied with that result. So with bleaching trays, I put her on Polonite 16% for a month. And I see her, and after 2 weeks, I see her, and we can see some improvement of the situation. And she didn't have any sensitivity. So I add a second bleaching agent, the Poladay. And after 4 weeks, look at the result. Okay, we can clearly see the defective restoration, but she is up to this point quite satisfied about the result of the bleaching on the lower teeth, and now it's time to fix the upper teeth. And what we did, again, trying to keep it extremely conservative, and what we did over there are prefab composite veneers and a lava bridge. I did put those prefab composite veneer with a backing of DC composite because I know that this material is quite opaque. And I did a small mistake over there. I didn't do enough. Reduction, and we can see a little dark area over there. But that composite, I can fix it later on. And when we compare the result at the beginning and the result at the end of the treatment, it is a huge difference with simple procedure that most of our patients can afford. And it's kind of weird because I saw that patient for recall treatment today, and she said, those treatments were life-changing for me. Now I can smile, and I was always putting my hand in front of my teeth because I didn't like my smile. And now she smiled, and she's very happy of the result. And this is a very simple treatment done in a general practice environment. So the idea is to we can see that composite technology is still improving a lot. And it's more and more interesting to practice dentistry now. We have super material that make us look sharp. And we have direct conservative restoration are major part of any general practice. I do CAD/CAM in my office. I take digital impression. But let's be honest, as a general practitioner, we will still do conservative restoration and direct conservative restoration. So having good material is a must in every practice. We have new material that improve improved feature that help dentists give better treatment. We are lucky right now because we have material that with impossibility that were not possible 30 years ago. And I strongly believe that bioactive material are the future of restorative dentistry. It is the topic of a future presentation. Okay, this is the end of my presentation. Thank you again for your attention.